Good afternoon, everyone. Welcome to the 12th VPS Research Spotlight presentation. I'm sure a few more will be joining us as we get along, but since this spotlight is only for 30 minutes, I want to make sure that our speaker has ample opportunity to present his work as well as to answer questions that the audience might have. Today's speaker is Dr. Colin Rogerson. Dr. Rogerson is a pediatric critical care physician, and he's currently an assistant professor of pediatrics at Indiana University. He obtained his master's in public health back in 2020 and has currently 3 active research grants and over 38 peer-reviewed publications. More importantly, one of his primary research interests is the use of informatics and data science to conduct clinical research and to improve outcomes for children with severe respiratory diseases. And in line with that, today he's going to discuss the publication from the Annals of the American Thoracic Society, which was produced just this past year, the title of which was The Institutional Variability in Respiratory Support Use for Pediatric Critical Care Asthma. This was a multi-center retrospective study. So without taking more of his time, I'd like to present Dr. Rogerson. Colin?
All right. Thank you, Dr. Rice. Great to be here. Thank you so much for the opportunity I have to present this research. I'm going to go ahead and share my screen or replace the current share and share my slides. All right. Is everyone seeing my slide deck okay?
Got it.
Wonderful. Awesome. So again, thank you again. It's great to be here. As you can see, this was an effort not just from my end, but I had a great set of collaborative authors who all helped make this publication and the research possible. So they're listed here, and I'll list them again at the end. But what I'll be talking about today is our study that we had to look at how different sites take care of critical asthma from a respiratory support standpoint. So I'll start with a little bit of background and then go into what our study did. So as many of you know, especially those who practice in the pediatric intensive care unit, pediatric asthma is a problem. It's the most common chronic illness of childhood, and most recent estimates say about 1 in 12 children in the US suffer from asthma. And even though a lot of these kids have pretty short stays and are often not the most acute patients in the unit, we do have some that don't respond to initial therapies and have pretty tenuous courses in the ICU and need advanced respiratory support devices, including BiPAP, invasive mechanical ventilation, and we do have a few every year that do die from asthma. We know that first-line therapies, especially from a medication standpoint, are pretty well established. So kids that get sick with critical asthma present to the hospital. They receive inhaled bronchodilators pretty quickly and systemic corticosteroids. And while most respond to those treatments, in the ICU, we see the ones that don't. And they end up receiving many more therapies, which are not necessarily evidence-based at this time. The same authorship group that published this paper, we worked on a study using the FIZ database that looked at ancillary medication use across institutions. But the FIZ database doesn't capture respiratory support quite as well and as granular as the VPS database does, which is why we chose VPS for our data source for this study. So respiratory support, again, it's not very evidence-based in what the optimal respiratory support to use for critical asthma is. If you look up national published guidelines by the American Academy of Pediatrics or the American Thoracic Society, they have fairly vague general statements about this topic that say things like use supplemental oxygen and positive pressure is needed because, again, there's no large randomized controlled trials that really show the best respiratory device or support to use for this population. And so there's really no definitive guidelines as far as whether we should use high flow or an oxygen aerosol mask, whether we should use CPAP or BiPAP, or when the right time is to intubate these kids. And so our hypothesis for the study is that due to this lack of good evidence, there's likely high variability in which respiratory devices are used to treat critical asthma in the pediatric intensive care unit. And we also thought that this variability is likely influenced heavily by institution and institutional preference. So when we're looking at institutional variability, the Virtual Pediatric Systems database is a fantastic resource to use. Again, it captures a wide variety of institutions, both across the country and outside of the country, large and small centers. And so that's why we selected VPS to use for this, to answer this research question. The population that we selected, we chose patients that were greater than or equal to 2 years old. Our time frame was from 2012 to 2021. They had to have a primary asthma star code, and we only used PICU admissions. If they were designated as a cardiac admission, they weren't included. The respiratory support devices that were captured in the study are the ones shown here. So VPS keeps very granular track of which device is used at which time. And so we designated patients that either received conventional oxygen therapy or an aerosol mask, high flow nasal cannula, CPAP, BiPAP, or invasive mechanical ventilation. For institutions, we wanted to split institutions into specific categories that would be meaningful and might influence the way that they practice. And so what we chose to do is we separated all the institutions that were included in the study based on their patient volume. And so we ranked them 1 to 5 and split them into quintiles. And quintile 1 being the institutions that had the lowest volume of critical asthma patients that were used in our study, and quintile 5 being the institutions that had the highest volume of pediatric critical asthma patients in our data set. We did a logistic regression model looking at respiratory device use and the factors that contributed to higher or lower odds of using those devices. And we also did a time series analysis. So moving into our results section, so our study population ended up including over 77,000 encounters for pediatric critical asthma across 163 institutions, and 7 of them were outside of the United States. The first figure that we wanted to show involves the use of these devices over time. So again, the time period stretched from 2012 to 2021 and illustrates the prevalence of use of each of the devices that we studied. So starting with kind of the top line, that light blue line was indicative of room air or conventional oxygen therapy or kind of your standard aerosol mask. So if you look at the left side of the graph in 2012, about 80% of all the patients treated in the ICU for critical asthma were treated really just with a conventional aerosol mask. And you can see as you move to the right through the study period that this percentage drops dramatically. And by 2021, only about 40% of patients are treated with this, about half of what it was at the start of the study period. So moving to the darker green line, which represents high flow nasal cannula use, you can see this is has the opposite trend. We're starting in 2012, about 12 to 13% of patients or encounters in the critical care unit used high flow nasal cannula, and then this increases pretty dramatically to over 50% by 2021. The darker blue line represents non-invasive ventilation or BiPAP, and this was probably about 5 to 6% in 2012, when it rose fairly consistently to close to 20% by 2021. The orange line is invasive mechanical ventilation, which remains pretty consistent through the study period at about 5 to 6%. And the purple line is CPAP, which is pretty low consistently throughout the study period, usually less than 3 to 4%. So this table represents the characteristics of the quintiles based on the institution. So again, quintile 1 being the lowest volume centers and quintile 5 being the highest volume centers. So you can see, looking at the volume numbers, the fourth row shows the average patients per year per institution. And so the lower volume centers only had about 2 encounters per year for critical asthma, whereas the highest volume centers had about 135 patients per year for critical asthma. So a large difference in the quintiles. We also measured their PRISM-3 score probability of death, and overall they were pretty consistent. Quintile 5 at first glance looks like it might have a lower PRISM-3, but was not statistically different. This figure has 4 different bar charts that illustrate each of the 4 devices used. And it has the percentage of use on the y-axis and then the institutional quintile on the x-axis. So starting at the top left and walking through, the figure in the top left represents high flow nasal cannula use. You can see that starting at the lowest volume quintile centers, about 30% of their encounters use high flow. And then once you get to quintiles 2 through 4, it jumps to about 35 to 36%. And the largest volume centers at quintile 5, that percentage drops to below 25%. Moving to the right, you see CPAP, which is overall pretty low percentage across all volume centers, with the highest being quintile 3 has about 6%, but overall pretty low and doesn't change much based on institutional volume. In the bottom left, we see BiPAP use across the quintiles, and with the lowest percent use being the smallest or lowest volume centers at quintile 1, about 10%. And you can see that this percentage of use increases pretty consistently up to quintile 5. So the largest, highest volume centers get close to 20% of patients that require BiPAP. And in the bottom right, we see invasive mechanical ventilation, which is thankfully fairly low, about 8% or less across all quintiles. But you do see a small, slight downward trend that as the institution volume increases, the use of invasive mechanical ventilation decreases. And so the largest volume centers have about 5% or less of patients that require invasive mechanical ventilation. This figure looks at the length of stay in the PICU based on institutional quintile. Overall, most centers have about a median of 1.8 to 1.9 length of stay in days in the ICU. But you can see pretty subtly in quintiles 1 through 4 that does get a little bit lower. And by the time you get to quintile 5, the length of stay is significantly lower in the highest volume centers compared to the lower volume centers. This table looks at the logistic regression model and factors that influence the choice of respiratory device. So starting on the first column with admission year, as the year increases, so as you move through the study period from 2012 to 2021, the odds of receiving high flow increase significantly, as well as CPAP and non-invasive ventilation. And the odds of receiving invasive mechanical ventilation do very slightly decrease as the study year increases. Moving to the age column, as your age increases in increments of 1 year, your odds of receiving high flow decrease. Your odds of receiving CPAP and BiPAP increase slightly, and your odds of receiving invasive mechanical ventilation decrease very slightly. Male sex seems to have a significantly decreased rate of use of high flow and BiPAP, and it's significantly larger odds of receiving invasive mechanical ventilation. PRISM-3 score, essentially as the PRISM-3 score increases, your odds of receiving any of the devices increases, but most significantly your invasive mechanical ventilation. And then looking at quintile, as the volume of center increases, your odds of receiving high flow or invasive mechanical ventilation decrease, but your odds of receiving CPAP and BiPAP increase. This is again another logistic regression model, but this is looking at the chances of respiratory support, non-invasive respiratory support failure. So the patients that received a non-invasive device and then required intubation. And so you can see admission year. So as the year increases, your odds of failing non-invasive support decrease. As the patient gets older, their odds of failure decrease. Non-Black race is associated with an increased rate of invasive mechanical ventilation use. And as your PRISM-3 score increases, your odds of failing non-invasive support increase. This is my last figure. This is what's known as a Sankey diagram. So this attempts to try and illustrate the flow of device choice for the patients in the study from one to the other. And so you can see kind of towards the top, the largest proportion of patients were started on high flow and then went successfully weaned to room air from high flow. The next largest proportion were on BiPAP, and they were able to wean from BiPAP straight to room air. But you do see smaller proportions of patients that essentially move through the devices. So you have patients that start on BiPAP and then wean to high flow and then wean to room air. You have some that wean from BiPAP to CPAP and then room air. You have some that fail high flow and go to BiPAP and then to the other devices and eventually get to room air. Overall, really just a way to kind of illustrate what proportion of patients receive what devices and how they move from one to the next. Overall, our study conclusions showed that institutional variability in respiratory support use for critical asthma is high. We found that the higher volume centers use more non-invasive positive pressure ventilation and less high flow and invasive mechanical ventilation. And we showed that treatment with high flow nasal cannula and non-invasive positive pressure has increased over time. Again, these are those to my co-authors who were instrumental in making this possible. I'm very grateful to them for their help and happy to have the chance to present. And I'm open for any questions. Thank you.
Thank you, Colin. Let's see if we get some questions coming through. I see one or two. Let's see. Oh my goodness. Jamie. Let's see if I can figure out what the question is here. You wrote a lot. Let's see, I'll just read it. Many of these methods of respiratory support were optional for VPS. Did you only use institutions who had chosen to collect all respiratory support methods you discussed, oxygen therapy included? Or did you make assumptions to include so many institutions? For example, my institution collects all NIV, IV, and HHFNC and always has, but we have never collected standard oxygen therapy.
So good question. The overall answer is that we discussed whether to try and only include institutions that reported all of those over the whole study period. But overall felt like that was going to narrow the population too much. And so we used all the information that was provided to VPS. When it comes to standard oxygen therapy or oxygen mask, what we used for that is really just the absence of any other reported device. So some centers did report that they used a nasal cannula or an oxygen mask, but if they didn't, but they also didn't report that they had received any of the other devices, then we assumed that they had received room air or oxygen mask, knowing that that's a limitation and likely isn't true for all encounters.
Great. I think most of the people that use the VPS or input data realize that we try to eliminate bias in the data collection. If you decide that your institution is going to collect a particular parameter, it becomes a mandatory field then for that, at least for that quarter, because you can't close that case out unless you've collected or answered that response there. So even though there may be institutions early on that didn't include that information, if they did include it, they would have not been biased and included all of those patients for that time period. So very good. Let's see. It looks like some more questions are coming in here. Gerardo has a question. So would the increase in OR in the non-Black race be a result of having a data set that has a majority of non-Black patients?
It's a good question. We had some potential explanations for why that race category was a factor in increased risk of failing high flow. It's possible that we just had more data in those patients. I don't have a definitive reason as to why we saw the increase in the non-Black population, but you're right, it could just be different representation from that group in the data set.
Thanks, Colin. I had a question. One, I want to comment here. I thought the Sankey diagram was very helpful in trying to understand some pretty complex flow issues. And as a co-investigator on a recent publication trying to sort out patients as they go through respiratory failure, I think it would have been very helpful in our publication if we had included something like that, because it gets very difficult to explain some of that in words. And I think the readers kind of get lost in how things are moving through the process, even though the data is all there in the tables. I had a question myself that all of the quintiles were sorted on the diagnoses, volume of critical care asthma patients. As larger ICUs and institutions, those institutions may often have more resources, such as an intermediate care unit or other areas within the hospital where they may be able to do some of the non-invasive, particularly the high flow and even continuous aerosols. And I wonder if, so in our case here, your patients that had, that were in the largest quintile, in other words, the highest volume, may not have been the institutions who have the largest number of these patients overall. It's just in the ICU. And so those institutions may have had most of their non-invasive sitting somewhere else, or some of their non-invasive sitting somewhere else in the institution. So I wonder if that's maybe a piece of the information that kind of skewed how some of that might play out in some of those units where you would expect those kind of units to have higher PRISM scores and probably a higher volume of actual invasive ventilation because they've already separated it out. And I just wonder, especially in light of your Phys article, where you're able to look at medications and some of those things, I wonder, you know, in the coming years, or sooner, I hope, when you can actually integrate these things together, the two data sources, whether or not that might shed quite a bit more light on actually how these devices and where they're actually being used within these units, as well as some of the adjunct therapies, such as the medications. That's more of a comment than a question, but I'd like to hear what your thoughts are on that.
Yeah, I mean, I think there's definitely some interesting things we could do if we were able to link the data sets together, like looking at the floor patients that get high flow. We did think that kind of the decrease in high flow use in that fifth quintile was probably because a lot of those large volume centers have intermediate units or just use high flow on the floor. And so their increased use of BiPAP and decreased use of high flow is probably just a sign that they take the higher acuity patients in their ICUs.
Yeah, see a couple other questions. Randall has two questions. One, did either the mortality or length of stay change over time? And then the second question is, did the incidence of asthma admissions change over time with regards to the unit themselves?
Good questions. Mortality did not change over time. ICU length of stay, the actual number went down, but it wasn't really statistically significant across the time period. It did decrease a little bit. Overall volume, I would have to double check the publication to see if the absolute volume changed over time. I don't remember off the top of my head. It's a good question, though.
How about when you looked at the Phys data, because the Phys data includes the whole hospital stay. And I don't remember if your paper there looked at the entire hospital stay or just ICU stay.
So that one looked at the ICU patients also. And it had a slightly different time period. And I, again, honestly would have to double check. I don't remember a huge change in the volume of patients over time. But I would have to double check.
Okay. Let's see if we have any other questions popping up here. I don't see any other ones here. I'd say, where do you go from here? What's the next step? since this is one of your babies, I know, at least because you've already done the one with the FIS database since this one. So what are you working on now? How does this go forward?
Yeah, so good questions. I kind of have two avenues similar to this. So I have one avenue looking at the ancillary medications and one looking at the respiratory devices and trying to overall come to provide some evidence about what works better than and what works less. And so I'm looking at kind of some of our newer data sets, bigger ones that have granular EHR data, so I have device settings and laboratory values, medications, those types of things. And so specifically, PedsNet is a newer one that I'm hoping to get funding to pay for. And then the PICU Data Collaborative is one that's available through the Policy group, for the pedal subgroup of Policy. It's right now eight ICU sites that have linked data, and it's expanding to about 19 to 20. And I'm building an asthma data set using that data. And the goal will be to try and look at both ancillary medications and respiratory support devices and look and see if we can do some comparisons to see what works better, high flow versus conventional oxygen therapy, BiPAP, magnesium versus aminophylline, like those types of things, because every institution practices very differently. And so we'll have some good comparisons to do.
Are you recruiting additional units for that study, or are you pretty well filled up?
So I can only use the units that are in those data sets, so either PedsNet or the PDC. And I'm both databases are recruiting other sites. So if anyone's interested and they want to help their institution onboard into those, feel free to reach out. I'm happy to help you learn how to do it.
That's great. Well, we're just about out of time. I wanted to make sure that nobody else has any further questions for you. I don't see any popping up on the Q&A board here. I certainly appreciate your work and look forward to seeing the future stuff that you're going to turn out. While I have a small audience here, I want to make sure that everybody's aware VPS is having their Quality Improvement Conference in Kansas City, starting the last day of April and extending the first day or so of May. Be great to have as many of you join us if we can. We're going to have quite a few presentations, mostly focused on quality improvement. And we're looking forward to making some new announcements of improvements within the VPS data set. Hopefully, one of them is going to have to do with the being able to link the FIS database with the VPS so that we can actually get some financial information and maybe some more detailed information regarding medications and other interventions that are done that we don't capture within the VPS. So unless there's more questions, I want to thank you again, Colin. Pleasure to have you join us. And thank you very much for spending the time with us, and good luck with your future research.
Thank you. Thank you for the invitation. It's been great.
All right. Thank you, everyone. Pleasure to have you on board today.